Hi, welcome back to your prescription for medication education. My name is Henry, and I'm a pharmacist, and I'm here to bring you quality information regarding medications and health-related topics. And today, I'll be continuing the hypertension topic, focusing on ACE inhibitors. Just like last time, I've decided to start off the video with a couple of questions. In this case, I have 5 questions, and at the end of the video, I'll go ahead and provide the answers. These questions aren't supposed to be extremely difficult. They're just questions based off of the information that I'm going to provide in the video. So question number 1, a 67-year-old man with hypertension and heart failure with reduced ejection fraction presents for follow-up. The medications include lisinopril, carvedilol, furosemide. His labs include a serum creatinine of initially was at 1.1 and it raised to 1.3 milligrams per deciliter. His potassium is at 4.9 milliequivalents and his blood pressure is 118/72. What is the most appropriate next step? Question 2. A patient develops facial swelling and airway tightness after several months on lisinopril. Which statement is most accurate regarding management? Question number 3. A 70-year-old diabetic patient on lisinopril develops a UTI and is prescribed trimethoprim sulfamethoxazole. His baseline potassium is 4.7. 3 days later, he develops weakness and an irregular heart rhythm. Which combination of mechanisms explains the complication? A bipolar patient stabilized on lithium begins enalapril for hypertension. 2 weeks later, his lithium level rises from 0.8 to 1.5 milliequivalents. Which physiological change is most responsible? The last question. A patient with hypertrophic cardiomyopathy and left ventricular outflow tract obstruction develops hypertension. Provider considers lisinopril. Which hemodynamic change would worsen symptoms? To better understand the mechanism of action of ACE inhibitors, let's do a quick and oversimplified refresher on the RAS system. The renin-angiotensin-aldosterone system regulates sodium balance and blood volume. It also affects vascular tone and the sympathetic nervous system. Renin is an enzyme that is secreted by the juxtaglomerular cells of the kidneys in response to reduced renal arterial pressure, sympathetic stimulation, or reduced sodium concentration in the distal tubules. Renin is responsible for converting angiotensinogen, which is made in the liver, to angiotensin 1 in the blood. Angiotensin 1 is an inactive peptide. Angiotensin 1 is converted to angiotensin 2 by endothelial angiotensin converting enzyme. ACE is a membrane-bound enzyme found on endothelial cells but can also be found on various organs such as the heart, kidneys, and has high concentrations in the lungs. ACE is also responsible for inactive bradykinin and other peptides. Angiotensin 2 can bind to either angiotensin 2 type 1 or angiotensin 2 type 2 receptors located in several tissues. Angiotensin 2 type 1 are found in the brain, kidneys, heart, peripheral vasculature, and the adrenal glands. Angiotensin 2 type 2 plays a minor role in blood pressure regulation and has the opposite effect of angiotensin 2 type 1 receptor activation. Activation of angiotensin 2 type 1 receptors leads to vasoconstriction, increased norepinephrine release, reabsorption of sodium in the proximal renal tubules, secretion of aldosterone from the adrenal cortex, and pro-inflammatory effects on vascular smooth muscles. In the heart, angiotensin 2 can be formed via a non-ACE pathway by chymase. This enzyme is responsible for about 80% of local angiotensin 2 generation in the heart, which results in increased cardiac contractility, hypertrophy, and remodeling in the presence of ACE inhibition. As an FYI, angiotensin 2 can be metabolized to angiotensin 3 and 4 that have their own biological effects, and ACE2 acts on angiotensin 2, creating angiotensin 1 through 7, which has its own effects as well. ACE inhibitors are competitive inhibitors of angiotensin converting enzyme, which results in decreased levels of angiotensin 2, leading to decreased vasoconstriction, decreased sodium and water retention, decreased cell growth and fibrosis, reducing cardiac and vascular remodeling, and decreased sympathetic activation. A secondary effect of ACE inhibitors is that they inhibit the breakdown of bradykinin, Bradykinin promotes vasodilation via nitric oxide and prostaglandin production. Some of the most common ACE inhibitors that I dispense include benazepril, enalapril, lisinopril, and ramipril. I won't go over every single ACE inhibitor individually, just a handful of them. In terms of efficacy, a 2025 systematic review and meta-analysis published in The Lancet showed ACE inhibitors reduced systolic blood pressure by about 6.8 millimeters of mercury and reduced diastolic blood pressure by about 5 to 6 millimeters of mercury for patients taking standard doses. About 60 to 70% of ACE inhibitor blood pressure lowering effects occurs with recommended starting doses. Of course, these effects are influenced by the patient's baseline blood pressures. Some of the adverse effects include acute kidney injury, angioedema, cough, and hyperkalemia. Some of the contraindications include idiopathic or hereditary angioedema or a history of ACE-induced angioedema, a 36-hour window of neprilysin inhibitor use, and pregnancy. Some of the warnings include hypersensitivity reactions, patients with ascites, patients with renal impairment, patients with hypertrophic cardiomyopathy with left ventricular outflow tract obstruction, and patients undergoing surgery. The FDA-approved indications include acute coronary syndrome, heart failure with reduced ejection fraction, and chronic hypertension. Captopril was the first ACE inhibitor on the market. Captopril has a short plasma half-life of about 2 hours and requires multiple daily dosing in the general population, which creates an unnecessary pill burden on patients. It must be taken at least 1 hour before meals, and when dosed for patients with reduced creatinine clearance, its dosing interval is extended to BID or QD dosing. The drug interactions for ACE inhibitors include oral layer, entrestol, sparsentan, trimethoprim, and lithium, which we will review a bit later in the video. Enalapril is a prodrug like most ACE inhibitors, which is converted to enalaprilat by hydrolysis. This ACE inhibitor is available in oral solutions which can accommodate infant and child weight-based dosing. The typical starting dose is 5 to 10 milligrams for hypertension. The oral solution requires refrigeration, and for patients with decreased renal function, its maximum doses are decreased based on creatinine clearance. Enalaprilat is mostly used in hypertensive emergencies. It's available in 1 ml and 2 ml vials with a concentration of 1.25 milligrams per ml. The dosing for enalaprilat is 1.25 milligrams every 6 hours, which can be given as an IV push over 5 minutes. The maximum total recommended daily dose should not exceed 50 milligrams. Enalaprilat's dosing is unique in which it takes into account whether a patient is on a diuretic or not. If a patient is on a diuretic or is at risk of severe hypertension, then the starting dose is reduced to 0.625 milligrams instead. When converting from enalaprilat to enalapril, the usual recommended starting dose is 5 milligrams, unless the patient has a creatinine clearance of 30 or less, which then the starting dose of enalapril should be 2.5 milligrams. The onset of action of enalaprilat is 15 minutes, with peak effects occurring within 1 to 4 hours. It's stable for 24 hours when mixed with a compatible solution. Lisinopril allows for once daily dosing, which helps improve drug adherence and can be taken without regard to meals. Lisinopril is the most prescribed ACE inhibitor in the United States, accounting for about 80% of new ACE inhibitor users across multiple large databases. Lisinopril and captopril are not prodrugs and are administered in their active form. The last ACE inhibitor I'll review is fosinopril. It differs from other ACE inhibitors in which it has a dual route of elimination. In patients with normal renal and hepatic function, about equal amounts of the drug are cleared by the liver and the kidneys. When either renal clearance or hepatic clearance declines, the body can compensate by shifting clearance of the drug to the other system. Because hepatobiliary elimination can compensate in the setting of reduced renal function, less accumulation occurs versus other ACE inhibitors. ACE inhibitors prevent the degradation of bradykinin, which plays a role in ACE inhibitor-induced cough as a side effect. Bradykinin itself is not the direct cause of the cough. Bradykinin activates B2 receptors in bronchopulmonary C fibers, which express substance P. When these C fibers are stimulated, it triggers the release of substance P in the airways and in the brainstem. Substance P acts in the nucleus tractus solitarius, which is the brainstem's cough center, to amplify the cough reflex. Cough develops in about 5 to 30% of patients on ACE inhibitors and can take 1 to 4 weeks to resolve after discontinuation, which is the time needed for bradykinin and substance P to return to pre-treatment levels. Increased bradykinin levels also contribute to ACE inhibitor-induced angioedema, which is rare. It occurs in about 0.1 to 0.7% of patients. It typically occurs within the first few months but can develop even after years of use. The American Academy of Allergy, Asthma, and Immunology recommends that patients who develop angioedema on one ACE inhibitor should not be switched to another ACE inhibitor, as this is a class effect and most patients who experience ACE inhibitor-induced angioedema can safely use ARBs without recurrence. Switching to an ARB carries modest risk of recurrent angioedema, somewhere between 3.5 to 10%. Hyperkalemia occurs because of reduced aldosterone secretion due to decreased angiotensin II formation. If you remember from my last video, aldosterone stimulates sodium reabsorption and potassium secretion in the principal cells of the collecting duct. ACE inhibitors can cause acute kidney injuries, but let's review why this can occur, how we can mitigate the risk, and find out if we should discontinue a patient's ACE inhibitor after an acute kidney injury has occurred. The reason ACE inhibitors can cause acute kidney injury is because they reduce intraglomerular pressure, essentially reducing the kidney's ability to filter. Angiotensin II preferentially acts on the efferent arterioles of the glomerulus, which normally increases the GFR. With less angiotensin II levels available, we end up with increased efferent arterial vasodilation and reduced GFR. Certain health conditions are dependent on angiotensin II to maintain adequate GFR, such as volume depletion, heart failure with low cardiac output, or bilateral renal artery stenosis. Volume depletion is the most important modifiable risk factor. Patients on diuretics experience acute kidney injury rates of 33% versus 2.4% without diuretics. Signs of overdiuresis include hypotension, fatigue, azotemia, and oliguria. Patients should be advised to avoid NSAIDs if possible and temporarily hold ACE inhibitors during severe episodes of acute illness. Serum creatinine should be monitored to evaluate kidney function within 2 to 4 weeks of initiation, and a serum creatinine increase of between 10 to 20% is expected. Patients who experience a creatinine increase of greater than 30% within 4 weeks should have the medication stopped or the dose decreased. Resuming an ACE inhibitor after an acute kidney injury is associated with significantly lower all-cause mortality and reduced adverse kidney events. ACE inhibitor-associated acute renal failure is almost always reversible if recognized early enough, with renal function typically improving within 2 to 3 days after cessation. Reinitiation of the ACE inhibitor should occur once extracellular fluid volume is repleted and the patient is hemodynamically stable. Fear of a recurrence of the acute kidney injury can often result in permanent discontinuation, which is the most common clinical reaction despite being associated with a higher risk of major adverse cardiovascular events and death. Exposure to ACE inhibitors during pregnancy, particularly in the second and third trimester, carries a significant risk of ACE inhibitor fetopathy. This condition represents a pattern of fetal injury categorized by oligohydramnios, cranial abnormalities, renal dysfunction, and in severe cases, fetal death. Oligohydramnios and renal failure are the hallmark features. After approximately 20 weeks of gestation, amniotic fluid consists primarily of fetal urine, making normal kidney function essential for maintaining adequate fluid volume. ACE inhibitor-mediated reduction in fetal angiotensin II leads to fetal hypotension and decreased renal perfusion, which disrupts normal kidney development. The most characteristic renal finding is renal tubular dysgenesis, which is an underdevelopment of the proximal tubules, which results in reduced urine production. This decrease in fetal urine output ultimately leads to oligohydramnios, defined as a low volume of amniotic fluid. When switching patients from an ACE inhibitor to an ARNI, angiotensin receptor neprilysin inhibitor, a 36-hour washout period is required to reduce the risk of angioedema. This is because both ACE inhibitors and neprilysin inhibitors block the degradation of bradykinin, which plays a role in triggering angioedema. The 36-hour window allows enough time for the ACE inhibitor to be cleared. The American Association for the Study of Liver Diseases explicitly states that ACE inhibitors and angiotensin receptor blockers should be avoided in patients with cirrhosis and ascites. This recommendation is based off of the pathophysiology. In these patients, they have a reduced effective arterial blood volume due to splanchnic vasodilation. These patients' blood pressure is maintained by a compensatory activation of the RAS system in response to splanchnic and systemic vasodilation. Higher survival rates for cirrhotic patients with ascites is correlated with a higher mean arterial pressure. Patients with a mean arterial pressure of 82 or less have only 40% one-year survival compared to 70% in those with higher pressures. By blocking angiotensin II production, ACE inhibitors eliminate this critical compensatory mechanism. Hypertrophic cardiomyopathy is an inherited heart disease. The muscles of the heart become abnormally thick, especially the interventricular septum. These patients often develop left ventricular outflow tract obstruction. This obstruction is highly sensitive to loading conditions. ACE inhibitors reduce afterload, which in most cases is beneficial, but not in hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy with obstruction, medications that cause vasodilation, such as ACE inhibitors, cause the left ventricle cavity to decrease and increase the velocity of blood flow through the narrowed outflow tract, which worsens the obstruction. The reduced afterload increases the Venturi effect, which creates a suction effect in which the mitral valve leaflet is pulled further into the outflow tract. Essentially, ACE inhibitors can precipitate hypotension and system exacerbation in these patients. In certain patients, intraoperative hypotension is a concern for patients on ACE inhibitors. This concern arises due to anesthesia-induced vasodilation, but for patients on ACE inhibitors, the RAS system's compensatory response to maintain blood pressure during the stress of surgery and anesthesia is impaired, which can lead to frequent and prolonged episodes of intraoperative hypotension. The American College of Cardiology and the American Heart Association recommends certain patients omit ACE inhibitors 24 hours before non-cardiac surgery to limit intraoperative hypotension. However, for patients with heart failure with a reduced ejection fraction, perioperative continuation of ACE inhibitor is reasonable. Oralair is an oral grass allergy immunotherapy tablet composed of 5 mixed pollen allergen extracts. It's used to treat grass pollen-induced allergic rhinitis. In the Canadian product monograph, the use of ACE inhibitors is contraindicated. However, in the US labeling, this contraindication isn't listed. The contraindication is based off of a theoretical increased risk for the development of angioedema. Although both of these medications can cause angioedema, the mechanism by which it occurs is mechanistically different. In the case of Oralair, angioedema occurs through an IgE-mediated route. This is important because angioedema caused by Oralair will respond to traditional treatment approaches consisting of antihistamines, epinephrine, and corticosteroids. Bradykinin-mediated angioedema has a limited response to these medication therapies. Sparsentan, brand name Filspari, is an endothelin type A receptor and a angiotensin II type 1 receptor antagonist that is used to slow kidney decline in adults with primary IgA nephropathy who are at risk for disease progression. Because of its angiotensin II type 1 receptor antagonism, it's contraindicated with ACE inhibitors because of its additive effect on the RAS system, leading to additive toxicities which can include acute kidney injury, hyperkalemia, and hypotension. Use of both trimethoprim and ACE inhibitors is associated with an increased risk for hyperkalemia. Trimethoprim blocks epithelial sodium channels in the distal nephron, which impairs sodium reabsorption and potassium secretion. Elderly patients, diabetic patients, and patients with a reduced renal function are at their greatest risk. Reduced renal function is the strongest independent risk factor for the development of hyperkalemia. ACE inhibitors can increase the steady state of serum lithium concentration. Because ACE inhibitors decrease intraglomerular pressure and reduce the GFR, this results in a decrease in filtered lithium, leading to lithium accumulation. ACE inhibitors also reduce aldosterone secretion, which decreases sodium delivery to the distal nephron and triggers a compensatory increase in proximal tubular sodium reabsorption. Because lithium reabsorption parallels sodium reabsorption, any medication that enhances proximal sodium reabsorption will increase lithium reabsorption and reduce lithium clearance. ACE inhibitors initiation in patients stabilized on lithium increases steady-state lithium concentration by approximately 36% and reduces lithium clearance by 26%. The answer to question number 1 is B, continue lisinopril and monitor labs. The answer to question number 2 is C, to avoid ACE inhibitors permanently and to use ARBs cautiously. The answer to question number 3 is A decrease in aldosterone and the blocking epithelium sodium channels. Question number 4 was B, which is a reduced glomerular filtration rate and increased proximal sodium and lithium reabsorption. And the answer to question number 5 is reduced afterload causing increased outflow gradient. That was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and feel free to leave me a comment below. And as always, have a great day.